Well, good morning and welcome to the first grand rounds, cardiology grand rounds of 2024. I'm Dr. Peter Kudenchak. I'm a professor of medicine, cardiology, and electrophysiology here at the university. And I am pleased to introduce Dr. Jason Coult, who is a research assistant professor in the Department of Medicine. He is going to be talking about some really exciting research that we've been involved with King County Medic One and King County EMS, and look forward, I think, to hearing his remarks, which I think you will as well. Let me tell you a little bit about Jason. He joined our motley crew in 2011 when he was a junior in bioengineering, and it began a collaboration we've had with bioengineering for the last decade plus, trying to develop improved methods of addressing cardiac resuscitation. Jason has been very prolific in his term of duty. He got his PhD degree and master's in 2019 and joined faculty. He's published more than 27 significant articles addressing mechanistic issues of cardiac arrest that he'll be discussing with us. And on the side, Jason has a second profession. If you're ever privileged to eat at the Canlis restaurant or the Space Needle Sky City, you'll see an accomplished pianist there that is Jason. So he balances his scientific endeavors with the arts as well. What Jason's going to be addressing specifically this morning is a study that looks at prediction of shock refractory VF during out-of-hospital cardiac arrest. And he's been kind enough to ask me to give a little bit of perspective clinically on this topic before he'll get into the technical details of how you go about doing something like that. So let me just give you some background. This year in the US, there'll be more than 370,000 out-of-hospital cardiac arrests. About 80,000 of those will be caused by shockable rhythms, the FVT. And the majority of those rhythms will not be terminated by shock, or they'll recur after shock, what we would term as shock refractory VF. And shock refractory VF is associated with worse survival. The foundation of our management of patients with out-of-hospital VF is the marriage between defibrillation and CPR. What you see on this slide is the odds of surviving to hospital discharge, a cardiac arrest from the time of collapse to defibrillation. Those are the red bars. And what you could call the slope of death, the red line indicating how survival declines over time when defibrillation is delayed. But the gold line is the marriage between the two, whereby providing CPR continuously and ideally minimally interrupted, the rate of decline in survival can be cut in half by adding CPR. And that's critical because every 1% declination in continuous CPR results in a 1% drop in survival. So you get what you pay for, and the two are intricately linked. Shock refractory VF is common. Here are data from the Swedish registry looking at 19,000 patients who had out-of-hospital VF. And you can see that over half of patients, 10,000 of them, required 3 or more shocks. More than a third required anywhere from 5 to 10 shocks, and nearly 10% required more than 10 shocks. And survival fell with each ensuing shock that was required in these patients, meaning there was a 10% likelihood of survival for every shock that was administered over that study period. So repeated shocks are not a good thing to have. What's notable is that the ACLS algorithm, this is the one from 2020, it will be a new one in another year, advocates treating shock refractory VF only after 3 shocks have failed. That's when antiarrhythmic drugs come into play. And what's important to appreciate is that by that point in resuscitation, we've lost a significant number of patients, probably more than a third have died as a result of that. And the question is, if we move that algorithm to treat immediately after 1 shock has demonstrated failure, can we change that outcome and improve survival from cardiac arrest? Well, there's some data that say that may be the case. The amiodarone lidocaine or placebo trial of out-of-hospital cardiac arrest randomized 3,000 patients with out-of-hospital cardiac arrest due to VF, who, if they failed 1 or more shocks, could be randomized to placebo, amiodarone, or lidocaine. Interestingly, although the study randomized patients after one or more shocks, a median of 3 or more shocks were actually received before the patients were treated. And the mean time to antiarrhythmic drug treatment ended up being nearly 20 minutes. So it's probably not surprising that the overall results of this trial didn't show a significant change in survival when you compared amio, lidocaine, and placebo. What's notable is last year, another study looked at the same data from this trial, but analyzed it in a different way, asking the question, what if you broke the distribution of these patients down from those who received drug early, meaning within 8 minutes of ALS arrival? That was about a third of the patients in the ALPS trial, or 8 or more minutes, which represented about 2/3 of patients, and looked at the same outcomes: survival to admission, survival to discharge, and neurological outcome. And what was observed is in patients who received these 3 interventions late, there were no differences in any of these outcomes. Survival to discharge, survival to admission, functional survival were no different. But interestingly enough, if you treated within 8 minutes, early administration, the difference between placebo and amio admission alive to hospital went from about 50% to over 62%, a 75% improvement. Survival to hospital discharge, comparing placebo and amiodarone, went from 28% to 37%, a 56% improvement. And neurological outcome went from 23% to nearly 32% with amiodarone, nearly a 55% improvement, meaning early administration of amiodarone, same trial I showed you, where no differences were seen. But if you gave the drug early, discharge, admission, and functional survival improved anywhere from 55 to 75%. A lot of lives that are potentially saved in process. So here's the question. It looks like if we treat early, we can make a difference. The question is, how do we identify the shock winners and the shock losers, those who require treatment in order to minimize repeated shocks and refractory VF, versus those in whom they don't not only not need treatment, but that treatment could be potentially harmful. And that's where we think the answer lies in energetics, meaning the characteristics of the waveform that is seen pre and post shock can potentially determine by that waveform whether a patient is going to be shock refractory or not. But the challenge is you have to look in order to see what's going on. Now, all of us can distinguish, I think in this slide, what's ventricular fibrillation, what's an organized rhythm, and what's asystole. That's easy enough to do. You can make that diagnosis. But look what happens to those rhythms when you include CPR. And remember, CPR is a critical component, and it's something you don't want to sacrifice. Now you throw in a shock, and how can you tell post-shock what rhythm is there? Is it VF? Is it an organized rhythm? Is it asystole? And if it is VF, what are the characteristics of what it might be? And that's the challenge that we have. How do we minimize interrupting CPR, the trade-off of which says you get a diagnosis, but you lose the ability to save a life because you're losing perfusion in that process? And yet, how can you continue CPR and still know what's going on underneath? And that's where the work that Jason and our team have done over the last decade or so, saying, can you determine from the waveform alone what's going on beneath CPR in someone who's in cardiac arrest? And the answer is you can't. By applying techniques that Jason's going to be able to explain and I really can't, you can discriminate an organized rhythm, and you can discriminate that from VF. And if your eye is like mine, you may not be able to see much in the difference in waveform, but you can see that in the top waveform in blue, an organized rhythm looks different than if you look on the blue graph below from ventricular fibrillation. And it's this kind of algorithm that can tell us what the rhythm is beneath CPR, and whether that rhythm is VF or not VF, and what the characteristics of VF might be that would be seen. The next step, and this is where Jason's recent publication comes into play, is can we use that same kind of approach to not only identify the post-shock rhythm during ongoing CPR, but to use that to predict whether that patient with that rhythm is going to fail shocks and require preemptive therapy, or whether that patient will be shock responsive and avoids the need for drugs that could potentially be harmful. Meaning using that tool can we predict VF in a reliable way that's going to be refractory in order to change treatment and advance treatment in that individual patient? So that's what prediction of shock refractory VF during resuscitation of out-of-hospital cardiac arrest is all about. And Dr. Coult is going to tell us the rest of the story.
Thanks, Peter, for the introduction and the much more excellent overview than I was planning to give at first. Yeah, my name is Jason Coult, and I'm a junior faculty doing research in Department of Medicine, working with Peter Gunchuk here and Dr. Tom Ray and others. And I was given this slide, and I will say that we don't have any financial interests, but the UW has applied for a patent for this method on our behalf, which we have waived any personal financial stake in. And Peter's covered most of this background, so I'm just going to skip through really quick. The basic idea here, again, is that right now resuscitation follows a fixed protocol that's sort of predefined and applied to all patients. And it's a compromise between doing CPR, during which time you're blinded to the status of the patient, and then pausing CPR, during which time there's no supported circulation, but then you can ascertain the patient's rhythm and vital status during those brief pauses. And again, the protocol dictates that after the third shock, the patient's considered shock refractory. And at that point, amiodarone would be given to the patient. And with this current protocol, two of the big shortcomings, again, are that CPR has to be paused to allow identification of the rhythm. Yeah, this pause can be harmful to the patient. And also that simply identifying what the rhythm is in terms of the basic actionable cardiac arrest state, this sort of ignores the spectrum of physiology that can happen within rhythms. We might want to call this actually phenotypes within a rhythm. And these sort of phenotypes, if you will, can be estimated from morphologic features of the ECG, which have been shown to be related to clinical prognosis. And perhaps if you could learn something about each of these phenotypes and provide that to the rescuers, those phenotypes could be used to guide care. So we don't want to just know what the rhythm is. We want to know something more about within each of the rhythms, things that are interesting about what might happen with the patient's prognosis. And these phenotypes could be used to guide care if provided to rescuers. Within VF or within organized rhythms, for example, they might be categorized the same during resuscitation, but they might have very different prognoses and therefore merit very different treatments targeted to the particular patient. Identifying the rhythm during CPR can be difficult, and even more difficult is trying to discriminate within individual rhythms to ascertain the particular prognosis of that patient by defining their phenotype. But if that could be done, that information could guide care based on the likelihood of a good or a poor outcome for that patient. So in general, our overall goal, what we're working on, are multiple algorithm modules, each to either identify what the rhythm is or to identify something within rhythms about a particular phenotype that's indicative of outcome in order to guide resuscitation care. The idea being that if you can ascertain rhythm and phenotype during CPR continuously, that could be provided to rescuers, and that information could be used to administer treatments. And so in this roadmap of projects that we've been working on, it includes identifying rhythm, discriminated among ventricular fibrillation rhythms, discriminating among organized rhythms, and also taking these individual modules and applying them in a predictive way to predict other interesting conditions that we would want to know about. Those conditions might include imminent rearrest of the patient, or in this case, the topic of today's talk, predicting shock refractory patients. In order to do this, we can use artificial intelligence methods that can learn information from the data to make predictions. And the more data we have, the more complicated models we can use, and the less hands-on we need to be in guiding those models in their design. So with a small data set, you might have to manually design features of that ECG signal that could be used to predict something about the patient. But the more data you have, the less human intervention you need when designing the models, and the more you can let the data do the talking and learn automatically from the data. So we're sort of increasing the size of our data set, and as we gather more data, increasing the complexity of the models that we're trying to use. And all these activities are enabled by the data that we have from King County EMS. These are out-of-hospital cardiac arrest recordings that contain clinical and defibrillator signal information. Once we get these cases, we can manually annotate the rhythms and the CPR state matched up with time-stamped interventions and also clinical outcomes of the patients. And then once you have this annotated defibrillator recording in a data set, you can query it for a particular project and pull out rhythms of interest automatically in sort of an efficient way. So we've been using this ongoing, growing data set for multiple projects, and it allows, sort of eliminates the upfront work that would be required to do these types of projects. And so today, as Peter mentioned, I am going to talk about that paper to predict shock-refractory VF within a paradigm of the current resuscitation protocol, excuse me. But I'm also going to talk about ongoing work to do this during a future hypothetical protocol where CPR is not paused at all to allow analysis, because under the current protocol, we're guaranteed a pause in CPR prior to a shock, because rescuers have to stop CPR for the defibrillator to detect VF and then make a shock decision. So we do have a CPR-free segment under current protocol, at least before the shock. But ideally, in a future situation where defibrillators and the protocol governing resuscitation does not require CPR pause, we would want to be able to run this type of a program during that paradigm as well. So as Peter pointed out, right now refractory VF is defined as actionable after the third shock is administered. At that point, antiarrhythmics are recommended. But ideally, we would want to know sooner if patients are going to manifest shock refractory VF, so that we can have a warning ahead of time to preemptively administer treatments. Right now, a protocol says that amiodarone can be given, but there might be also experimental treatments that the clinicians would want to administer if they knew a patient was going to be shock refractory. These might include maybe trying ECMO or modifying the shock delivery strategy, other techniques to mitigate refractory VF. So the reasoning for designing an algorithm that would predict refractory VF stems from other works that we've done that suggests that characteristics of the ECG before a shock and after a shock are both independently predictive of the patient's prognosis in general, and also that temporal information in the progression of ECG rhythms and phenotypes following shock is strongly indicative of prognosis. This paper is from Dr. Bhandari, one of our colleagues, and shows that after VF shock, there are distinct progressions of rhythm states, and that these progressions of rhythm states are indicative of prognosis. And so using information about the ECG before and after shock, and also trying to leverage this sort of temporal progression of rhythm evolution, these are things that we could use in any sort of prognostic algorithm, including predicting refractory VF. So this method, again, operates within current protocol, where we're assuming there would be a pause before the first shock available during VF, and then a period of CPR following the shock, where we'd have an artifacted ECG as well. And with the idea being that the defibrillator could give a warning to the rescuer that refractory VF is likely and allow earlier antiarrhythmics than would otherwise be given. And again, with our data set, the rhythms are already labeled. We can query the data and pull out segments of the ECG that we need for this particular project. Here are some examples before and after the first shock of patients that were shock refractory and not, to show you what we're sort of working with to feed into the algorithm. We've got different manifestations of VF, sort of different phenotypes before the shock. And then after the shock, we see that there's CPR artifact concurrent with actually maybe several different kinds of rhythms. I like this top example because it happened to capture the rhythm at the point where reentry occurred, I think, where you can see that it's smooth, and then there's a sort of an underlying VF signal that's riding on that CPR artifact. So the post-shock ECG is collected regardless of the rhythm label, taking all comers and then using this information to predict refractory VF. Because that second ECG after the shock is collected during the scheduled 2-minute period of CPR, most of the time we have to deal with CPR artifact in that signal. And as Peter pointed out, there are some time frequency techniques that can be used to mitigate the effects of CPR on the signal itself. And in this case, this post-shock ECG is likely organized. It's to the eye, sort of hidden in the tracing, and it would be hard to design manual features to pick those peaks out, perhaps, during CPR. But using time frequency analysis, you can sort of exclude CPR artifact from the signal. And again, these colored plots here show the energy on the vertical axis corresponding to time on going into the screen, and then the frequency going across the screen. So the frequency is measured in hertz, which is cycles per second, where 2 cycles per second, for example, would correspond to 120 compressions a minute. And so a little bit less than that, we see about maybe 110 compressions a minute. There's a band, and that's the band that's resulting from the fundamental frequency of CPR and the signal. But we can ignore that lower frequency information and focus in on the higher frequency information in order to learn something about the ECG while ignoring most of the CPR artifact. In order to use machine learning in order to predict shock refractory VF from these time frequency images, we have to be able to give the algorithm a small enough set of numbers to describe each patient's sample. So if you feed in just a raw ECG or one of these images raw to an algorithm, there are so many numerical values that unless you have millions of samples, the algorithm won't be able to learn which things are important and which are not. So in this case, we're doing machine learning. We're not doing deep learning. And that means that we have to guide selection of the features before we feed those features into an algorithm. And so if you have on the order of maybe 1,000 patients, that would mean you don't want more than maybe a few dozen features to describe each patient, rather than feeding a whole image with hundreds of numerical values. So we can use some statistical techniques to reduce the dimensionality of samples representing each patient. In this case, this example is showing singular value decomposition, which is where we can take training data. In this case, it's a stack of those time frequency images that represent ECGs. We can take that stack of training data and perform this transformation to find the information in the training data that has the most independent information. So these are called singular modes, where we transform the training samples into the same number of samples that are sorted into these singular modes. And each singular mode represents sort of an orthogonal piece of information about the data, some way that the data varies independent from other ways. So this lets us select just a few sort of transformed time frequency images that are generated from the training data. And these few transformed images represent the most important information about that data set. so that we can have just a few representative images of the entire training data set. And here we have selected 3 based on, or actually this example shows 10, but we can sort the modes by the information they represent and then just retain a few of the most important ones. And we're going to call this an eigenscalegram library, eigen referring to the decomposition, scalegram referring to the fact that they were generated from time frequency scalograms. And then library, because we want to save this subset as an important set of features that we're going to use for our machine learning algorithm. If you have a library of sort of representative information of the most important things happening in these signals, these again are called modes, we can take a new signal that we don't know anything about, and instead of having hundreds or thousands of numerical data points representing that time frequency information, we can just compare it to that library of important features and use those comparison values as descriptors of the input signal. So here, instead of having thousands of data points for the image, we just have 3 values that represent similarity of that image in terms of those 3 important features that we generated from the training data. And then we have those 3 numbers which represent that input, and those 3 numbers quantify the most important things about that data. And those 3 numbers can be fed into a classifier and used to train and validate a model to predict refractory VF. The procedure for doing this machine learning project was to separate the data into training and test sets, and then within the training data, do some sort of pseudo training test, and then shuffle, and then do it again, shuffle, so that you could simulate training a model and then applying it to new data multiple times in order to select what kind of model is best, select what frequencies you're looking at, things like that, before you actually train a final model and test it on another set of data. Using this process, we selected the library of the most important features to use against which to compare inputs, and the machine learning model to discriminate those similarity values of a new input versus the library in order to predict refractory VF. Here are 2 examples. On the left, we have a non-refractory patient. Again, pre-shock VF, no CPR, and then post-shock rhythm during CPR. Those ECGs are transformed into time frequency and then compared to that library of only the most important features from our training data and quantified in terms of that library, in terms of their similarity to each of those important features, whether it's positive or negative, and what's the value. And then those values are fed into the machine learning classifier, which can predict refractory VF. We ended up having over 1,300 patients available for this study. And the survival in the refractory patients was significantly lower than the survival in the non-refractory patients. And these results just sort of support the prior investigation that Peter showed, where more shocks is correlated with poorer survival. And this is the distribution of the number of shocks. So more than half of patients required 3 or more shocks in our data set as well, supporting the prior investigations on this. We're going to skip this slide, but here are here's the exclusion and inclusion tree and the characteristics of the patients. And we could quantify the association of number of shocks with outcome. And we did see, of course, that there was a significant reduction in the chance of pulse and eventual survival the more shocks were given. So this just highlights that we want to intervene earlier to reduce the total number of shocks and the total time that is spent in VF for these patients. And again, we might be able to do that if we predict refractory VF in advance in order to intervene early for those who will be shock refractory. And the validation performance had an area under the receiver operating characteristic curve of 0.85 for this method, again, that operates within current protocol. Because the model gives a probability output and not a binary decision, you can set classification thresholds based on the comfort level of making a decision. So if you're considering a treatment that is has potentially a greater risk you might want to have higher specificity when making this decision. But if you're considering a treatment that is less risk, but maybe a greater upside for the patients, maybe like giving early antiarrhythmics, you would want to select a classification threshold that tends to be more sensitive so that you don't miss out on the shock refractory patients and don't deprive them of the chance to receive the early intervention. So for this paper, we do see that it is possible to predict shock refractory VF. The performance isn't perfect, so there's, hopefully the next study doing this type of work will even beat our numbers, and we'll get even better and better until it gets, eventually implemented into clinical practice. And it is compatible with current protocol without requiring a post-shock pause for analysis. But we also want to make sure that this could work into the future, where we hope that all defibrillators will analyze the rhythm continuously during CPR in determining whether the rhythm is shockable or not. And so the protocol might not require rescuers to stop compressions every 2 minutes to analyze the patient. And if that happened, we wouldn't be able to use this previous shock refractory algorithm that we've developed. So this ongoing work is, I'm just going to describe some of the approaches we're taking to make sure it could work in a future scenario where there was no pre-shock pause. It might look something like this, where instead of pauses before each shock, the defibrillator would just warn and then warn that the rhythm is shockable and just give rescuers a brief moment to deliver the shock, and then they can resume CPR. And so in this case, we would want to do everything we can to boost the performance of the algorithm and mitigate the effect of the CPR artifact, because before the shock, during VF, the CPR is going to be obscuring a lot of that information about the VF signal that we were using before. And also, this approach we're taking tries to leverage more information about the evolution of the rhythm post-shock. And so instead of just one snapshot, we're taking 3 in order to capture some temporal sequence of time evolution of the rhythm, which might be able to be leveraged to improve performance. So for this method, again, the first of the 4 inputs was collected during CPR before the shock. And then the second, third, and fourth segments were collected at regular intervals following the shock. The longer you wait after shock to make a decision, the more time has been lost, but the more information you've captured. So we sort of selected a compromise of 60 seconds following shock is where we're going to stop reading and make a decision, giving us enough time to sort of measure the progression of post-shock rhythm, but not waiting too long to make a decision that could be useful. And this is more challenging, partially because in the post-shock rhythm, you're dealing with any possible rhythm that can occur during CPR, ranging from asystole, organized rhythms, ventricular fibrillation. And so there's a broader spectrum of information in that post-shock rhythm. And that broader spectrum is a little bit more visible during CPR, where you could probably discriminate QRS complexes from the smoothness of asystole, from the roughness of VF. But before the shock, during CPR, we only have VF signals. And in that case, we're not identifying what the rhythm is. We already know it's VF. In this case, we're actually quantifying the phenotype of the VF, the spectrum of VF physiology that can occur prior to shock. And in that case, the CPR artifact is more of a problem, because VF's frequency range is usually from the 3 to 8 hertz range. A really nice VF might be happening with a rotor about 8 or 9 cycles per second. And then poor looking VF would be fine in amplitude and slower perhaps. And that VF could be obscured by CPR, not only at the fundamental frequency, which is a little bit slower than the VF, but actually from the transients and the harmonics of the compressions, because the chest has sometimes got a bounce that causes artifact at the multiples of the fundamental. So not just 2 hertz, but 4 hertz, 6 hertz perhaps. And then the individual transients themselves may be caused by perturbation of the electrodes or spikes, electrical artifact. Those can bleed into the VF signal, making it hard to discern something about the VF. previous papers, we've tried to use active filtering to remove CPR artifacts. It's possible to estimate the frequency of CPR from the impedance signal, which represents the physical changes in the chest due to compressions, and then to target the assumed CPR frequencies based on that frequency. But again, in this case, you're throwing out some of the VF information with the CPR information. So we've tried to opt for a more data-driven approach on this algorithm rather than actively and aggressively filtering the CPR artifact. If you look at the data set in aggregate, where you take the sort of the average frequency content of all signals of all patients, just to get a sense of what's included in the ECG here, we can see on the left here, we have ventricular fibrillation without artifact. There's a sort of a distribution of frequencies of VF. As I said, it's usually between 2 hertz to maybe about 8 or 9 or 10 hertz for the really robust VF. And then on the right here, we have the aggregate spectrum from over 1,000 patients of VF during CPR, where we see the introduction of this band that's maybe 3 times the energy of the VF band on the left. And during the CPR band is bleeding into the VF frequency range and obscuring it partially, although it is centered to the left a little bit, so it's obviously the fundamental is lower. And then again, on the right here, this is a 1-minute aggregation of post-shock ECG information, where we have the strong CPR band that bleeds into the rhythm information to the right of it. But there is information to the right of that band that's not really affected by the chest compressions. So this suggests that there's a range above CPR where there might be a mixture of artifact with ECG information. And we can maybe grab some of the useful information above CPR while ignoring most of it if possible. Here's a specific example where we've collected a signal before the shock and then 3 progressive segments after the shock. And I chose this one again because you can look at the signal and see that there might be a progression of rhythms happening where 5 seconds post-shock, you see, maybe with your eyes, you can kind of see it in the ECG. There's a little bit of a spike, a blip that might be CPR, but that might be complexes. And then 30 seconds post-shock, there might even be larger complexes. But 60 seconds post-shock, you see a little bit of fuzziness riding on top of the CPR artifact. So it's probably in VF at 60 seconds. So there's a progression there of not only individual rhythm states changing, but within rhythms, the phenotype and morphologic features are evolving. And so all this information is useful to the machine learning algorithm as it's trying to learn what is indicative of refractory VF. And again, we can take our training data, which consists, again, of a stack of these time frequency images that represent each ECG segment. And we can take the stack of training images and run this decomposition to generate only the most important features of that data. And we can use that to generate libraries that represent the most important features that describe the data based on the amount of information represented by each of these transformed modes. So if you retain just a subset of the most important 9 modes generated from the training data set, you get this nice library of what features are most important about pre-shock VF and what features are most important about post-shock all rhythm ECGs. And because this algorithm is having a harder time making a prediction due to the CPR artifact, we wanted to take one additional step and exclude, be a little more selective about which characteristics of the ECGs we're going to use for prediction. So we might exclude 1 or 2 features, even though they might represent a lot of information about the signal. Those the amount of information represented might not be actually predictive. So there might be something that's unrelated to refractory VF that still was statistically interesting in the data set that we want to throw out and not use in our classifier. So we can use some statistical techniques to try to determine what characteristics of the ECGs are important at different points in time. So there's a progression of rhythms that are happening post-shock, 5 seconds after shock, 30 seconds after shock, 60 seconds after shock. And in aggregate, there might be different things about segments at those particular times post-shock that are important. So here we see that the optimal features of post-shock rhythms are different 5 seconds post-shock than 30 seconds post-shock and 60 seconds post-shock. So this indicates that we're incorporating something about the temporal progression of rhythms as well as their individual features. And we can do another cross-validation training procedure on this data that's all during CPR, again, to optimize our model and the frequency ranges and the libraries of features that we're using in order to train and test the final model. And here's an example of the final algorithm where, again, I like this example because we have pre-shock, there's some artifact, it looks like a spike, and then there's some compression cycles there during the VF. And then post-shock, we have what looks like CPR during probably asystole. There might be something underneath there, but I can't really tell. But then 30 seconds after shock, I think reentry is happening. 60 seconds, it looks like some kind of weaker VF, a fine VF with a few compression artifacts, just showing that the rhythm is changing over time and that we're using different features that we learned from the training data to describe each of those rhythms and then feed them into a machine learning model. In this case, we use something called a support vector machine. The last method used a random forest. These are just different statistical models that can make predictions based on input data. And in this continuous CPR approach, we had less patients, but still over 1,000, and the performance was reduced by a few percent. So it indicates that we still can predict refractory VF during CPR, but you might lose 1 or 2% or 3% sensitivity on the performance. And it does indicate that there is potential, though, to do this technique, whether or not CPR is being performed continuously, or whether we're in current protocol where we're afforded this pre-shock pause that sort of improves performance slightly. And it does suggest, it really did seem that there's useful information in the ECG, not only looking at an isolated segment from a random point in time, but in structuring your sampling so that you take segments at fixed points in time in relationship to the shock, and then using that information, feeding it into the algorithm, because a patient's response to the shock itself is prognostic, and we want to make sure we leverage that dynamic response that the patient has to the shock, because it does indicate a lot about their physiology. And we did indeed confirm that shock refractory VF is common, more common than I had thought. It's most patients, more than half, have this condition. It's not a small subset. And they do have a much poorer outcome, and it is possible to predict them in advance. And an earlier prediction could enable interventions like a drug or early hospital transport or ECMO or any number of experimental methods that the clinicians might decide they want to try. And this could hopefully improve outcome for these patients rather than just following the current protocol where you wait until they've already suffered from this prolonged time in VF, multiple repeated failed shocks, until you then decide to intervene. It'd be better to be proactive, take action earlier. And in one, I don't know if I'd call it a shortcoming, but a next step for this work would also be to determine the specific phenotype of shock refractory VF. So if they're predicted to be refractory or observed to be refractory, we would want to know if it was due to incessant or recurrent VF, because in the case of incessant VF, you know that the shock itself was not effective, and that might indicate you might different ideal treatments for that patient, such as maybe an antiarrhythmic. But if it was recurrent, where the shock was electrically successful, that would indicate other treatments as well. And maybe Peter could explain this better than me, but these are two slightly different groups of patients, and ideally we would be able to distinguish them in order to best target the treatment. And then I want to acknowledge our team of folks from UW and from King County EMS. And I'll take any questions now. Yes.
Jason, that was a fantastic talk. I have two questions. For the first part, my question is, maybe you said this, was there a performance difference on the pre-CPR versus the first post CPR? Because there's a cost, right? 2 minutes, of not administering, let's say if you don't give amnio. So was the performance difference in terms of predicting refractory VF if you use the pre-CPR versus that one post-CPR?
Oh, you mean the pre-shock?
Yes.
Okay, so
pre-shock, sorry.
if you're limited to the pre-shock VF only, yes. So ideally we would make, are you asking what was the difference limited to that?
Yes.
Yeah, so that was our first attempt, and the AUC was like 0.61 or 2. So it was there was significant information in the pre-shock VF alone, but just relying on that, it wasn't good enough to want to be useful. So the longer you the longer period of information you include after the shock, the better the performance got.
I see. So I guess presumably it's just more data, right?
Mm-hmm.
Okay. And then for the second part, would you have these algorithms on a particular patient, are you treating them as independently? Because there's some time information, right, that is lost if you're treating each of them independently, like 5 seconds, 30 seconds, 60 seconds. Are they all, does the algorithm know this is like the same sequence in terms of timing?
The segments, the algorithm knows which segment was collected when, if that's what you're asking. So it knows that second segment is always the one 5 seconds post-shock. The third is 30 seconds post-shock. And then it can leverage that, yes.
But for the same patient, does it know that it's from the same patient? It's just an independent. You see what I'm getting at? Because you have patients and you have ECGs or data. Does the algorithm know that the one at 5 seconds, this is the next one over at 30 seconds and the next one at 60 seconds?
Yes, the order is preserved because it would know, variable number 7 into the model is the one that was from the 30-second post-shock versus number 4 is from the 5-second post-shock. And then there's an interaction between those two. So yeah, it leverages that temporal information.
Right.
And it can exploit sort of nonlinear relationships between each of those time points. And that was the hope. And that's why it didn't work very well just using the pre-shock VF. It's because there is a lot of information in not only the VF morphology and the myocardial energetics of the VF itself, but in what did the heart do in response over time. And that's what we had to include. That was Dr. Kwok's idea, actually, is to include the post-shock information.
Thank you.
Which was required, yeah. Yes.
Hey, Jason, thank you for this talk on a complex topic. In the beginning, Dr. Kudenchuk was mentioning how early administration of amiodarone led to enhanced survival benefits. And are you guys in discussions because in the future steps you mentioned testing this algorithm in different systems? Are there also discussions to see whether use of these algorithms would impact survivability?
That would be a next step to the next steps, I suppose, like a prospective investigation. Right now, I'm not looking at that, but that would be the dream if it worked well enough. But you would want to validate it in many different ways before you would, before you would apply it to patients to actually measure the difference in survival using this to inform care, because there's a lot of, just the fact that it's a high-performing system means we're sort of overfit to King County's data, it might not generalize as well as we hope. You don't know. So you'd have to test it on lots of different kinds of data from different devices. They all have different filtering bandwidths, all these different things. So yeah, a lot of external validation would need to happen first before you'd feel comfortable doing a clinical trial like that.
Hey man,
Hey.
thanks for coming. Well, here's my coffee. I have two questions. The data for the continuous CPR, where did that come from? Are we doing that?
No, so that's a great question. I had to just simulate what would be available. So this is what it would look like in theoretical application, but to actually gather the data, I just took our current data, which has a pause before the shock, and then I took a segment right before the pause during chest compressions. And then for all of these segments, I visually confirmed the presence of CPR during the VF too. And so it's not quite the same as would be available in a continuous CPR, but we took the nearest artifacted VF before the shock during
Cool.
CPR. Yeah,
That makes
great
sense.
question.
And then the predictive likelihood of refractory VF, is this a moving data point? Like as we're doing CPR on a person and they've had 3 shocks, 4 shocks, is the prediction increasing early on? Does it start at 60% and say, oh, now we're at 90%?
If you trained new models that allowed longer data, you could improve the prediction as you got more. But on this one, we chopped it off at 60 seconds after the first shock. I figured if you waited till after the second shock, well, you're already pretty late. So
Totally
it's not
makes
really
sense.
useful but yeah, the longer you wait, the better it gets. So if you're limited to just 5 seconds after the shock, the prediction actually goes down a little bit. And if you allow yourself to have a 90 seconds post-shock segment, the prediction goes up. So the longer you wait, you've got more data, you've been able to look at what the evolution of rhythm was, and then that's correlated with the refractoriness.
So in your mind right now, we would wait for 60 seconds and then the machine would give us a number.
Yeah, and that was mostly because it seemed to be, I have a continuous plot, but I actually plotted the performance of how long do you wait versus how good of a prediction.
Yeah.
And there's sort of a curve where it's diminishing returns. If you wait another 10 seconds after shock, it boosts it significantly, but if you wait it longer and longer, you get less and less benefit from that.
Cool.
Great
Thanks.
question. And I think that's it. Thank you.
Might give a 10-second overview of I've been fortunate enough to sit or unfortunate enough to sit on guidelines committees for a few decades with the American Heart. And it's interesting where we've been, where we are, where we're shortly going in long term. If you go back a few decades ago, we were interrupting CPR all the time, saying, what's the rhythm? Is it VF? Is it asystole? Is it, whatever. And we would direct therapy at rhythms we could see. And it was clear that didn't work because as you interrupted CPR, whatever you gained in knowledge, you lost in viability. So that changed, right? We went into a continuous model. You look at the rhythm, you shock the rhythm, you give a drug for the rhythm, and then you do CPR. And now all your treatments are blinded because under CPR, you have no idea what that post-shock rhythm is. Let's assume you shock a patient and the rhythm goes into sinus tachycardia and you give epinephrine. Well, you can probably guess the next rhythm you're going to see is VF, right? So we're in the phase of treatment being blinded. Where we're going is saying, wouldn't it be nice not to have to interrupt CPR and be able to know with high probability what the rhythm is beneath CPR? And we're there now. The algorithm that Jason's talked about with respect to identifying VF or non-shockable rhythms during CPR post-shock is before FDA right now in a particular defibrillator vendor. And that will come out in a defibrillator that will tell you during CPR, this is VF while you're doing CPR. The far future is why can't we predict even more than what the rhythm is, but how responsive that rhythm might be to treatment. For example, this is VF, but you don't want to shock this VF. It's not vigorous enough. You want to either give epinephrine to change it. You want to give an antiarrhythmic drug so it won't be refractory, or you would just want to keep doing CPR in order to get perfusion better. Now we can do what you would call smart resuscitation or precision medicine in resuscitation that tells us not only what we can do, what the outcome would do, but we never interrupt perfusion in the whole process of it. And I think that's the miracle stuff that Jason's getting to, how AI and this modeling, and frankly, I don't understand this, the pictures you saw. My APGAR poor score does not grasp those, but fortunately we have people who do understand that. And as clinicians, we can then adapt that and do trials. So in reference to the question, once you know you can predict, wouldn't it be nice then to do a randomized study saying, would treatment now change the outcome? And we're not there yet, but we will be. And you can see future trials. It won't just be randomly giving drugs, but randomly giving drugs with a specific intent in mind, because you knew what predicted and what didn't predict. So I will shut up at that point. I knew I had to fill the time to 8:30. It's now 8:30 and I think we're done, right? Okay, thanks.